All right, and we will begin. So welcome everyone to our exciting presentation today by Ron Unger on trauma and psychosis, exploring the intersection. The Community and State Hospitals section of Division 18 is really excited to present this for everyone. And we're thrilled by the level of excitement we've been receiving from folks and the number of attendees that we have here. Before I introduce our presenter, a few housekeeping items. I will be monitoring the chat and the Q&A. So if you have any questions as we go throughout the presentation, please feel free to drop them in the chat, drop them in the Q&A, and I will bring them up for Ron to answer at the end of our presentation. I have also dropped the link to our post-session eval in the chat. I'll drop it again at the end. And I've also put Ron's email in the chat, and I can provide that again at the end as well. We're really excited, as I said, to welcome Ron Unger, LCSW, to speak to us today and to learn from him. Ron is a therapist and educator specializing in cognitive behavioral therapy and related approaches for psychosis. He completed his undergraduate work in psychology at the University of the State of New York at Albany, and he earned his master's in social work from Portland State University. He is currently a licensed clinical social worker in the state of Oregon. Ron is particularly interested in the intersection of trauma, dissociation, psychosis, and spirituality, and his work is informed by his own personal and family experiences of that intersection. Ron chairs the education committee of ISPS US, is an active continuing education provider, and blog recoveryfrompsychosis.org. So we're really excited to have him here with us today, and we welcome you, Ron.
Yeah, thank you very much for that introduction. So to get started, I just want to kind of observe that first that when we're thinking about the relationship between trauma and psychosis, just to notice that they're commonly seen together. People with psychosis, they report high rates of adversity and trauma in their past, and then the prevalence of post-traumatic stress disorder in that population is pretty high, like about 5 times that of the general population rates. So what is the effect when you do have, psychosis and PTSD co-occurring? Because that's one way to think about the intersection. And one thing we notice is just that symptoms in general seem to be higher, social functioning is worse, quality of life is worse, as well as when people do get into care, they end up using care more, but have worse outcomes from it. Even the medications don't seem to work as well when people have both psychosis and PTSD. So, and then unfortunately, despite the commonality of people with psychosis having PTSD, that it's often not recognized in that population. Like when they look at it, it's sometimes not even in people's charts, or if it is in the chart, they are not offered trauma-focused treatment that would be aimed at, helping the person with the PTSD. So I'm starting just to looking at just the co-occurrence as though there's 2 separate things that just kind of happen together, trauma and psychosis. But a deeper question is, could trauma be the cause of psychosis, not just of PTSD, but of psychosis itself? And it's still kind of common for people to answer no, that something like psychosis or schizophrenia in particular is biological in origin and not caused by events. But the research seems to be saying something different, that there's a lot of evidence that psychological trauma could be a contributing cause for psychosis, lead to higher rates of schizophrenia. And the body of research now includes many large-scale population-based studies that do control for mediating variables. I want to look at the types of evidence because it's really, they're looking at it from a bunch of different directions. So one of the directions is to look at people who've been traumatized and then see, as we follow up, how many end up with psychotic symptoms or psychosis. And that's pretty high if you look at it starting in that direction. What if you look at it the other way? You look at people who come in with psychosis and then look at, do they have trauma histories? Turns out that's a real high incidence. And some people would say, well, maybe they're just reporting trauma because of their psychosis. And that does happen sometimes, but they studied that too and looked at when people with psychosis report, for example, trauma in their childhood, can that be corroborated? And they find out actually it can be corroborated about as often as when people who don't have psychosis report, traumatic childhood. So it seems like on average, it's pretty reliable, even though not always. And then there are studies that show that the greater the severity of the trauma, the greater likelihood of more psychosis and more intense psychotic symptoms. And the most dramatic study to that effect showed, they looked at people that had multiple types of trauma and found that people that had all 5 of the different types of trauma they were looking for, they were 193 times as likely to have some psychotic symptoms. And overall, the link between having multiple types of trauma and psychosis has been found to be as strong as the lower end of the estimate of the link between smoking and lung cancer. So it's pretty strong. And then another thing is the brain changes that are sometimes linked with psychotic symptoms and schizophrenia are also found disproportionately in people that have been abused as children. So, we think, oh, there's something different on average in the brains of people diagnosed with schizophrenia. That must mean it's a biological illness. Well, in fact, maybe it's brain changes in response to adverse events. And then finally, there's just logical and meaningful connections often between psychotic symptoms and normal reactions to traumatic experience. And we'll get into that a little more. So the levels of possible relationship between trauma and psychosis, it's kind of tricky. Now, because in addition to trauma being a possible cause of psychosis, it's also true that psychosis in turn can cause trauma. And sometimes that's by getting people to perceive danger when they're not really in danger. But if you think about it, psychological trauma has to do with the perception of danger. It doesn't have to do with the reality of it. So in other words, if I'm really in danger, but I don't perceive it, I won't get psychological trauma. But if I perceive that I'm in horrible, horrible danger, and even though I'm actually not, I can still get traumatized by that because I'm believing it. So that's one way that psychosis can cause trauma. But another way is that psychosis and disorganized behavior causes people to get into terrible situations. And so that can create more trauma for themselves. And then once research has found that people with psychosis, once they do experience trauma, they're actually more severely affected by it. They're more likely to get PTSD in response. And then also that people with psychosis will behave, like, for example, in ways that cause responses that are traumatizing. And part of that is they often drive away family and friends and lose that support, or even, stir up a lot of criticism and stuff. And then once they're in the mental health system often ends up resorting to force, stuff like seclusion, restraint, and forced medication. And while some of that stuff may sometimes be necessary, it does have often a traumatizing effect. And then once the person is experiencing more trauma, that can in turn around and produce more psychosis. So in other words, you can get a lot of vicious circles going, the trauma causing psychosis, causing more trauma, causing more psychosis. And people can be stuck in that for a long time. especially if they don't get help or get the wrong kind of help. So one of the things is I want to make sure it this comes across that I'm suggesting to be sensitive to the possible role of trauma in with people that have psychosis, but don't assume it. So there's no assuming like somebody's parents were bad or that they had a bad childhood. We're really interested in what's the actual story, what factors can be identified, and obviously in any one story we're never quite sure, but we can say, well, it seems like it could have been this and could have been that. Does that make sense? And feeling it out with people. And there's often multiple possible factors that could have contributed to the psychosis. And there's usually a story that interacts in kind of a nonlinear way. And then the various factors interact. And in fact, you can look up the catastrophic interaction hypothesis. That catastrophe happens because of a number of things going wrong that intersect. So some of that might be adverse experience and trauma, but then maybe in response to that, the person turns to substances to feel better. And then because they're using substances, that's really hard on their brain, plus it really keeps them awake. Maybe they're using a lot of methamphetamine or something like that. And then that, creates, then maybe they get a head injury as a result of their chaotic life. There's a number of things can go on. And sometimes, you see people that they really don't have any, like what we'd see as think of as overt trauma, but their stress is just built up to some catastrophic level for more subtle reasons. Like maybe they learned that they, had to be perfect to be okay. And then trying to be perfect is really stressful. Obviously, if people they're more sensitive in some kind of ways, that can lead to be more easily overstressed or traumatized. There's all sorts of things that can interact and lead to the psychosis. So we definitely should not assume that there's any particular trauma or kind of trauma. And in some cases, trauma may not really be part of the story at all. But when we're thinking about this, I think it's useful to step back and think also what exactly is psychological trauma. And I think it's very hard to pin down exactly what sort of events might cause psychological trauma. And I see reason to question the DSM when it tries to specify that, only certain kind of threats can cause psychological trauma. Like they'll say, well, threat to your physical integrity or the threat of sexual violence. But then they'll also include, well, maybe the trauma of hearing someone else talk about their trauma. And the reason I think that's in there is because as mental health practitioners, we know, hey, that can be traumatizing. But there's other kinds of threats that people might get traumatized by that are not included. Like if you think you're going crazy and no one's ever going to understand you again, could that be traumatizing? What about if you think your immortal soul is going to be lost to Satan forever? Is that possibly traumatizing? And then there's slower adverse experiences, or we could call them traumas, like poverty or the experience of racism. So poverty and racism can also make people more vulnerable to, more dramatic traumatic incidents that can also have a slower effect over time to build up issues. This graphic is one attempt to show how systemic racism can, in diverse ways, make psychosis more likely. It is a multi-dimensional problem. And there's a lot of complexities. For example, one complicating factor to be aware of is that African-American people are in many places more likely to be given a diagnosis like schizophrenia when that is not justified. It's just that doesn't really fit what's going on with them. But it also seems that the rates of psychosis are legitimately higher in that population. And that's for the reasons, including probably some of those that are outlined in this graphic. Anything that leads a person to have a sense of not fitting in can lead to more vulnerability to trauma. and then more likelihood to experience psychosis. It's been found, for example, that being a second generation immigrant, the children of immigrants, the first generation of first descendants, so second generation. And that's especially for people that are darker skinned living in lighter skinned areas. In other words, you're more different. Now, the one place in the world where being a second generation immigrant was found not to result in a higher rate of psychosis was for Jewish people immigrating to Israel. And that's presumably because they had a sense of fitting in. Hey, we belong here. But the exception was dark-skinned Ethiopian Jews who immigrated to Israel did have higher rates of psychosis, didn't fit in as well. So there's also evidence that adverse experiences related to being a sexual minority result in higher rates of psychosis. And then there's other kinds of things like experiencing neglect or just the lack of love and belonging can be an adverse experience that can make people more vulnerable to being traumatized. Like one way they measure how stressed out people are is cortisol levels. And one study, I just kind of read the summary of this, it said that experiencing deep loneliness results in as high a cortisol levels as being punched by a stranger. Now, I don't know how they tested that, like if you had to go into the experiment and be subjected to being punched by a stranger to see how your cortisol levels were changed. But anyway, that's what they reported. But I think the basic idea is right, that not fitting in and being isolated can make people feel really vulnerable and subject to trauma or even a form of trauma. Using a wider definition of trauma, I think, follows the basic CBT model that it's not events that distress us, but our appraisal or interpretation of them. And when we think of that in mind, it's kind of nonsense to try and only define certain types of events as traumatic, because that neglects the role of appraisal, right? So I think it's an appraisal that results in some combination of terror and helplessness. So the terror is the sense that we must do something or it's going to be horrible. And then the helplessness is I can't do it. Like if we see a truck coming at us and it's terrible, it's going to crush us, but we can jump out of the road, we won't be traumatized. But it's when we're helplessly held there and the truck is headed for us that we're subject to trauma. So trauma puts us into a mental state that's kind of the exact opposite of the serenity prayer. In the serenity prayer, you focus on what you can do and let go of the rest. In a traumatic situation, you feel you have to do something, but you can't. And that's where you're really feeling stuck. So to be traumatized, you have to have certain attachments to having to do something, and so, for example, there are some people who face their imminent death, but they are not in a state of trauma. And the reason is because they're able to let go of that sense that they need to live longer. So somebody, finds out they've got a fatal illness and they're going to die in a few weeks. They manage to let go of, well, I've had my life, I can let go, I could say goodbye to everyone I know, and then, go through that kind of peacefully and not in a traumatized state. And then you see other people that have a breakup with a partner and they just absolutely cannot find a way to let go. And it does become trauma. So I think paying attention to your client's actual story, how did something actually affect them? And there's a whole story to that, like the person that gets traumatized by the loss of relationship, there's often some reason they felt like they couldn't let go. And then some things, they might not, adverse experience, even if it doesn't, we wouldn't say that it's quite whatever your definition of trauma is, it still creates a higher risk of psychosis. Like we know from the adverse childhood experience or ACEs study that a variety of childhood adverse experiences make a whole variety of mental health difficulties, including psychosis, more likely. So just be aware of that. I thought I'd pause for a minute and see if anybody has a question that should really be asked before I go on here. Am I being clear enough so far?
We have one in the chat. And the question is there evidence that self-reported trauma that may not necessarily fit the criteria of PTSD trauma is associated with increased risk of later developing psychosis?
Yeah, I don't know if somebody's done like research about looking at that, because usually the research, they're looking at stuff that would be considered child abuse or obvious trauma. But I think there's reason to think that it's more like it depends on the person's story and how it affected them. And it's when people lose their ability to sense that they can cope and are fitting in, that they become more vulnerable. That would be my explanation. Anything else right at the moment? All right.
Would anyone else like to drop a question in the question, answer, or the chat boxes at this time?
Yeah. So, I'd say if trauma and near trauma is actually a major factor in causing psychosis, I think it's useful to step back and think, well, why has it been that the mental health system hasn't been very good at recognizing that and responding to it? So I'm going to look, at a number of possible reasons that probably play a role, and you might be able to think of more. But one of the reasons is just, there has been a lot of hope that a simple explanation would be found. And some cases of psychosis do seem to have a biological cause. Well, maybe they all do. So for example, if Huntington's disease can cause psychosis, well, okay, well, maybe, we can just find the genes and find the biological cause, and then we'll find an answer. So that's been a hope, but I don't think that hope is kind of panning out. And then there's a tendency to believe that if biology is involved at all, it must be the primary thing. And John Reed, he's a researcher that's done really a lot to uncover the link between trauma and psychosis. But he says he would go to lectures where they were talking about, how psychosis is biological and offering all their evidence. And he would raise his hand and he would say, "Excuse me, what are brains for?" And everybody would look at him like he was an idiot. And then he would say, "Oh, but if brains are meant to be responding to the environment, is it possible they're meant to change as they're in a different environment? And then so biological differences might indicate that the brain is doing what it's supposed to do." So in other words, if maybe the biological changes you see are the brain's response to a traumatic experience. Now so the biological changes can be secondary, and also if the person gets healing experiences, the brain might change back, and that's consistent with evidence that shows that when people respond well to therapy for psychosis, their brains do seem to change in healthy ways. So I think there's been excess focus on the role played by genes. I'm sure there's genes affect vulnerability. It's even been found that genes affect who's vulnerable to get PTSD. But we don't know, just because somebody has psychosis, that they have any particular genetic vulnerability at all, any more than when somebody gets a sunburn. Doesn't really mean they're genetically more vulnerable to sunburn. They might have just stayed out in the sun way too long. So yeah. And then there's, pharmaceutical companies and their allies definitely have, pushed hard towards, biological explanations, because that makes people turn more towards drugs as a solution. And then also that I think that the mental health field has been, there's a history to the mental health field having not taken trauma that much into account. Now, in a lot of areas, trauma is pretty strongly recognized these days. But if you look back, not even that far back, well, it doesn't seem that far back to me, since I was already an adult in 1975. It might seem like ages ago to some of the younger people here. But anyway, in 1975, the Comprehensive Textbook of Psychiatry, a very respected source of information, estimated the prevalence of incest. And I ask you guys this, about what percent of the population would you guess they estimated experienced incest? Does anybody want to take a guess? You can type it in the chat or unmute and say it.
Okay, we have a couple guesses. We have 2 to 3%, 40%, 20%, less than 5%.
All right. Okay. So the actual estimate they put in there was 1 in a million. And so 1 in a million. And Bessel van der Kolk, he's a trauma expert now, but he was trained during that period. And he said, not only did he hear the 1 in a million estimate, but he was told that if incest did occur, that it was liberating and the person experienced that it had improved mental health. So that's what he heard in his training. Now, obviously, recognition has improved a lot over the years of the role of trauma, the prevalence of abuse and its effects, but it hasn't quite reached the psychosis field, I think, the way it should. Now, on the other hand, there was in the past, some people were pointing to trauma as a cause, but they got overly carried away. And they started assuming, oh, well, you have psychosis, there must be trauma. What did their parents do to them? So got associated with parent blaming and that sort of stuff. And of course, I think that caused groups like NAMI to dig in their heels the other way, oh, it's completely biological. It has nothing to do with any life events. Kind of a defensive reaction, which is partly justified because there were people automatically blaming parents. And I don't think we should make any assumptions about parents and we should be curious about the actual story, but we shouldn't be making assumptions. So another thing is calling it a parallel process. That's where both the client and the mental health system and maybe even society overall get organized in the same kind of way in parallel. And so a person who's been traumatized may not want to recognize the connection between their current experience and their trauma. And so they try to block it out. And so maybe they're having flashbacks, but they don't want to believe that it's, has an association with a trauma. So they think it's demons. And then the mental health system gets organized in the same way. It doesn't want to have to dig into people's past. So it says, well, no, it's not demons, it's schizophrenia. That's what's causing those weird experiences. And both demons and schizophrenia are unseen entities that explain everything, and you don't have to pay any attention to the person's story. It seems, simplistic. I mean, it keeps you from having to dig into anything, but I think it's not a healthy process. And I think also when mental health workers haven't been able to face their own trauma, or they don't know how to face trauma, that can also make less willingness to even consider that as a possibility. And then last reason I'll look at is that there's been a thought that if trauma causes a mental health problem, it will be PTSD. And often, of course, trauma does cause the reactions that get labeled PTSD. But I think trauma creates many other kind of problems that don't get that label. In order to get a PTSD diagnosis, you have to be able to kind of like see that the memories of the trauma coming back are kind of like organizing the symptoms, or the symptoms are in reaction to that. And if that's less obvious, maybe the trauma is buried a little better, and or it's coming out in some weird way, that it'll get some other diagnosis. Now, well, we look at stuff like the ACEs study, it's not just like the people with bad childhood experiences have higher PTSD, they also have higher depression, they have higher anxiety disorders, they have higher OCD, and they have higher psychosis. So trauma can come out every which way, and that's a better way of understanding it. Now, it's also, I think, useful to look at that what we think of as PTSD and what we think of as psychosis actually have a lot of common factors. This slide lists a whole bunch of them: high arousal, hypervigilance, sleep disturbance, avoiding things that maybe really aren't dangerous, everything from avoiding remembering the trauma to avoiding things that remind you of it or something like that. Emotional numbing, which of course in psychosis comes across as more negative symptoms. Selective attention, often selectively paying attention to evidence of threat. Safety behaviors, that's a term in CBT that we use for when the person is doing something they think is keeping them safe, but it actually keeps them from finding out they don't need to do it. The whole thing of like not thinking about the trauma can be understood as a safety behavior. And that's why exposure therapy goes in the opposite direction and says, hey, maybe you can face what happened and find out it won't destroy you. Trying dysfunctional thought control strategies, expressed emotion causes relapse. That means, when people around the person are more critical or over-involved or hostile, that tends to cause relapse. That's for both PTSD and psychosis. Dissociation involved in both, intrusive phenomena. And the main difference is that in psychosis, there's a culturally unacceptable interpretations of those intrusions. Talk a little more about that. And historically, I think it's also worth noting that a lot of what are now seen as PTSD symptoms were historically frequently seen as part of schizophrenia. And also, this the commonalities. Like one study looked at combat veterans with PTSD and found, well, 35% of them also reported hallucinations and or delusions. So there's just a lot of kind of mixed kind of stuff. Now, this slide takes a look at some of the common processes involved in PTSD and psychosis, and also a common place where they diverge. So you have a person, if you look in the bottom, there's where the experience trauma box, and that leads to a lot of things. It leads to emotional responses, cognitive behavioral responses, beliefs about self and others. And in turn, then the arrow goes up to the top, it leads to post-traumatic intrusions. There's some kind of intrusion that, and then that intrusion, how is it experienced? And so on the left, it says, well, if the person relates it to the trauma, it might even be, I'm having this weird feeling in my body, but that's the feeling I had when I was being raped. And so I think that's a body memory or emotional flashback or something. Well, then, the person's reporting that, they'll definitely get a PTSD diagnosis. But let's say they have the same experience in their body, but they think, a demon is doing this, or my neighbor is beaming something at me. Well, then it's, as the slide puts it, a culturally unacceptable interpretation, and it will be, regarded as psychotic. But it's the same kind of process. It's the same process going on. It's just in one case the person is, less willing to see it as related to the trauma. And then this slide looks at, a lot of you probably have heard of complex PTSD, which has not made it to the DSM yet, but it has made it to the ICD, or International Classification of Diseases, or something, whatever that stands for. So, they say complex trauma comes from combination of the traditional PTSD stuff with disturbance and self-organization. which in disturbance in self-organization is like affect dysregulation, negative self-concept, disturbance in relationships. And so like, affect dysregulation, beliefs about oneself as diminished, defeated, or worthless, accompanied by feelings of shame, guilt, or failure that kind of comes out of traumatic events, difficulty in sustaining relationships and feeling close to others was, of course, is stuff that's all real common in people that get psychosis. And there are researchers trying to look into like what kinds of adverse experiences are more likely to lead to particular kinds of psychotic symptoms. Like it definitely needs more exploration, but it's been found that child sexual abuse is more associated with like voices, while emotional abuse and neglect is more associated with paranoia. And then they tried to understand why that might be, and they think, well, the stuff around sexual abuse probably has more to do with emotional regulation, whereas the emotional abuse and neglect probably more strongly influences beliefs about self and others. But anyway, this is a work in progress, but I think it's worth mentioning that complex PTSD conceptualization, how that relates to psychosis. So take a look at, well, what's been the impact of the failure often to see the link between trauma and psychosis. And a lot of people have, experienced that. And it's not uncommon for people, even with severe trauma histories, to be in the mental health system for a long time, sometimes like a decade or more, without trauma issues being addressed or sometimes even being asked about. I worked with one guy who had an extensive trauma history. Then he was diagnosed with schizophrenia. And then he was treated for 40 years with just medications. Medications that still left him struggling with many uncontrolled symptoms as well as side effects. And yet when he finally did get into therapy, he was able to strongly benefit from that therapy that addressed the trauma. And when people, there's no discussion of the possible impact of the person's story on their experiences and their symptoms, that just sort of makes them feel like they're just not understandable. I just got something scrambling my mind, like an illness is scrambling my mind. Even though there often definitely is a story. Now, one of the most dramatic illustrations of that around the turn of the century, somebody did research into what was going on in mental hospitals in Israel. And it actually seems at that time, about 2/3 of the people in the mental hospitals were Holocaust survivors who often just had been diagnosed with schizophrenia. Nobody had addressed, any trauma. So that was changing some at the time. Somebody actually made a documentary about it called Last Journey into Silence. But the scope of the problem sometimes can be pretty big. But, so this slide looks at the dimensions of the change needed. And so on the top, it just says make all, services in general trauma informed. And I think there's more definitely talk about that these days, being aware of the kinds of impact trauma has had on people and taking care to avoid re-traumatization within treatment as much as we can. But then I think this isn't done so often, is adding an option for trauma-focused treatment. So if we know somebody has experienced trauma and maybe still has effects of it, offer them treatment that focuses on the trauma. And that might be something like EMDR or exposure therapy or rescripting therapy. And research shows that people with psychosis who also have obvious trauma symptoms can benefit from just therapy that focuses specifically on the trauma. And then, ultimately, I think what we want is to really fully integrate trauma treatment within treatment for psychosis. And there's some good preliminary results and some studies where they did try to weave it all together, but I think we could, that's where I'm hoping we get to. Then what facilitates that, actually being able to do that? Well, here's the 3 most important factors according to one study. One thing you need is a coherent understanding of the relationships between trauma and psychosis. And that, of course, is what I'm trying to help us towards with this webinar. And thanks for all your interest in it. And then to get the structural support, well, it really helps when supervisors and administrators also have this coherent understanding, and they're willing to support clinicians and actually addressing the issue and taking the time to do it and getting the support they need. So that would be really important. So maybe some people attending today are such administrators and supervisors. And then clinicians need to feel that they can stay safe enough and that they can keep their clients safe enough as they work, right? So I'll talk a little more about safety. Now, there are a number of studies now, including randomized controlled trials, that do support the idea that having trauma-focused therapies, include memory processing, are safe, acceptable, and effective for people that have, like, both, let's say, PTSD and psychosis is often the way they've looked at it. And then I'm not sure this is always true, but at least some of these studies have found that symptom exacerbations are actually no more common or sometimes less common for people receiving treatment than they are for people on the wait list. So, that's a lot of people are afraid to do trauma-focused therapy with people with psychosis because, oh, they're not stable enough and it'll just stir everything up. But in fact, I mean, they're living with the trauma anyway, and it's often popping up in its own way and stirring things up. And so it's important not to be too scared of getting in there and doing the work. Wait a second. So, in trauma treatment, it's about helping people experiment with finding more healthy ways to carry and make sense of the memories. It's not making the memories go away, but they're find ways to carry it differently. And we can do things to work on creating more safety while we work with people. Like, some therapists say, well, let's create a panic button, something you can do if you feel like it's getting overwhelming. But then when people do feel overwhelmed, it's not like, okay, now we need to never talk about it again, but hey, we need to regroup and then we can come back in and talk about it. Our goal is both having people be able to face the memories, but also turn away and realize there's way more to life than their trauma memories, right? So it's kind of a back and forth. Pendulation is one way to talk about this, back and forth. Now, as far as safety, some people think, well, maybe we really need to work on stabilization before we turn to face trauma. And that's actually not clear in the research that you always need that, though a lot of times, the therapists do that anyway. Working in a hospital, we're talking about working in hospitals. One problem that comes up with that is that clients may not feel like the hospital itself is a safe place. That they've experienced forced treatment and don't experience as safe. So what's the solution to that? Well, one thing, the more we can work on making hospitals a friendly place, which I know there's a lot of work been going into that, then people feel less traumatized being there. Also, sometimes you can do work to help people just get along better with the staff, and then they'll start feeling safer and more ready to do the work. And then you can also work on establishing, in your relationship with the person, really being a safe person. Maybe you're safer than other people they've interacted with in the hospital. And then safety for clinicians is also an important thing. There might be exacerbations because they happen whether the person is on the wait list or in treatment. But it's important, not to blame ourselves. Like I said, it might have happened anyway. And if we have that structural support, then the system isn't going to be blaming us. Oh, you shouldn't have talked to them about the trauma. I think there's been a problem with mental health professionals being trained to prioritize avoidance, not just of trauma, but also other kinds of difficult experience. In the past, at least, clinicians were often told, don't talk to them about their voices or their delusions. That'll just make things worse. And I think that fits the definition of what Sandra Bloom called risky risk avoidance. In other words, you think there's a risk and you're trying to avoid it, but it's actually very risky to avoid it. Because as Peter Bullimore said, when clinicians don't open the can of worms that is people's traumatic experience, then they can't heal. They need that can of worms to be addressed. So a possible reframe is that, people have learned skills sometimes to push the trauma away, and those skills, they're worth something because it is good to be able to turn away from the trauma at times. But what we're really aiming at is people can turn away from it into the present moment, but they can also turn back and face it. And that back and forth, that pendulation. Oh yeah, the other thing for safety for clinicians is what about vicarious traumatization? And that's where having good support for the clinicians, as well as maybe clinicians who have done their own work on their own trauma, that helps make them be ready to do that kind of work. So just as an example of how somebody might map out being ready to do trauma focused CBT for psychosis, this looks at it in phases, and they do put in here a stabilization phase, and then we'll kind of like share a formulation, and a really simple formulation is, hey, it sounds like a lot of bad things happened to you. That might be partly what you're reacting to now that is kind of, pushing you into extreme states or psychosis. But let's try to understand that and, or look at how maybe PTSD kind of stuff is part of your current problem and how we might address that. And so then, you look at, there's different kinds of, it's got little arrows for kind of things you might do. Some there's cognitive restructuring. Here they're using a imagery rescripting approach, which is just one kind of approach to trauma. I think obviously people can also use, EMDR or other kinds of trauma approaches. But rescripting is if you guys don't know it, it's kind of a fun approach, and there's more complex forms of it, but sometimes it's just really simple things. Like I was working with someone who had truly horrific abuse and beatings by their dad. And now one thing that was happening is they thought that it was the ghost of their dad that was, coming into their minds, and they totally have a psychological collapse when that happened. And so I just introduced the idea, and that, hey, maybe something could come into your mind that was very powerful, that would be an ally. And, if you think this is a ghost, it could be something on a spiritual level that's very powerful. What would you like it to be? And, I kind of smiled, and she came up with this image of a wolf dog because she loves dogs. And the wolf dog came and jumped on her dad and knocked him over. And the thing is, months later, that was still working as a solution. Dad would show up, wolf dog would show up, and that took care of the problem. It was, so anyway, that's a really simple one, but you can learn about rescripting if you're into it. So anyway, but you have, you address this stuff. You You also might work with the schemas that came about. Often people have been abused a lot. They come up with beliefs about themselves. I'm no good, or, evil is going to always overwhelm me. The different kinds of schemas that you could work on. So it's just, and then, once the person has done the basic work, they would go into relapse prevention and work on staying well. So this is comments from some people that were able to experience integrated treatment for trauma and psychosis. One is like, it's being woken from a lifelong coma. I can actually start to live again. And if you don't talk about it, the root of the trauma is still there. It just keeps coming back, and you end up in repeated vicious cycles. I wouldn't be here today if I wasn't referred. Not only did it help me recover, but it was educational and empowering. So that's what I think we're aiming at. So I think we have a little time for questions.
I do, and we just received one in the chat. And this question is, what are your thoughts on the issue of implanted memories? Individuals who have experienced trauma, individuals experiencing psychosis, and especially those at the intersection may be at a heightened risk of suggestibility and misattribution when discussing past trauma.
Yeah, and the next webinar in this series, I'll be talking a little more about like when you're not sure what's being talked about is something that really happened. And a lot of it is working on clarification of getting more details and seeing how the person came to their conclusion that something happened, and how and being willing to stay in a place of uncertainty if we really don't know. And then also just helping them cope if they have the beliefs that something happened, but maybe we're not sure. We can still say, well, when you think of we can help them cope with, even if they're imagined memories that come in, well, how they can cope with that when those memories seem to pop in. Just like if somebody had a memory of Satan coming to them and torturing them, it's like, okay, we might think, well, maybe that didn't really happen, but in their mind, they're having that experience. So how can we help them, cope and deal?
Excellent, thank you. We have another question. What are your thoughts on brain spotting? I've been hearing about it more, and I'm wondering if it would be something that could be used here.
Yeah, I'm guessing it could. I don't know that much about brain spotting, but I think just like EMDR, it's a chance that, anything that works as a trauma treatment probably can also work with psychosis, and there might be details you need to figure out. I wouldn't be able to tell you.
Okay. And then our next question, do you believe the trauma should be addressed and treated in acute inpatient psychiatric settings too, when the therapist is seeing the patient for only a few sessions before they go to outpatient care?
Probably you probably would only be treating it in the sense that it's coming up acutely. I think there probably what's most important is to think about how can you, maybe just, you might share it as part of a formulation that like, wow, you had these bad things happen to you. That could be part of what it is, maybe, and then try to steer the person towards, some kind of treatment that will address that. And of course, that's easier if you've got support and there is treatment in the community you can send the person out to. But for example, really simple kinds of treatment, like I mentioned that example with the person with the ghost of their dad. That could be done in a hospital quickly. It didn't take a lot of time. So there might be some things that you could do that would be empowering, right at the time, but a lot of it would be steering the person towards treatment outside.
We have some more great questions. Are there any conditions in which trauma-focused work would be contraindicated?
I would think, if the person is in a really, I was talking about pendulation, going back and forth. And so if a person is all like agitated and, then I'm more like, well, let's work on getting into the turning towards a way, finding a way to be safe and okay. And even then, as somehow it might help, you might be doing something about the trauma to help the person get to that safety. But then once they're at the safety, it's going back. And I can't think of I don't think the research has uncovered like any particular kind of person that can't have their trauma addressed. I haven't encountered that. I'm not aware of it. But there might be times in the moment where you think, well, the most important thing to do right now is to get more into the moment and get okay right here. And then when you're feeling strong enough, turn back towards the trauma when you're ready.
Thank you. And then another question we have here is, would you modify your approach to treatment of trauma in a patient whose psychotic symptoms are in remission?
I don't. I mean, it just might be more straightforward, like straightforward trauma treatment. In that case, it wouldn't have the complexity of the psychosis being mixed in. That's the main thing I could see there. And you might, and often when I'm working with people in remission, I try to help them kind of unpack how the psychosis happened. And so you might be looking at some of the connection between the trauma and the psychosis.
Excellent. We'd also gotten a couple of folks asking if the slides would be available to attendees after today's webinar.
Oh yeah, I did. Have I sent you the slides? I don't even know.
Yes, and so I just wanted to check with you because I can send them out to folks if you're okay with that.
Yeah, I'm fine with that.
Fantastic. And then I know you mentioned briefly the next webinar that you'll be presenting for us. I don't know if in our last minute or two you want to give a brief blurb about what that one will cover and when it will be, in case folks are interested in attending that one as well before we wrap up.
Oh, let's see. I'd have to look on my calendar when it is, or maybe
Yeah, I believe it's Friday, March 21st or 24th.
24th. That would, yeah.
That's actually a Friday, yeah.
So we're gonna especially be talking about how helping people recover their sense of a story and making sense of so it's sort of like a narrative approach, but yeah, helping and because I think a lot of what both trauma and psychosis does is it just really disrupts a person's sense of being a coherent person with a story, and getting back to helping people feel like they have a story that makes sense, even if the story did involve getting, thrown into chaos for a period. That's what we'll be looking at, how to help people do that.
Well, I, for one, am very excited for that presentation next month as well. As a reminder for attendees, Ron's email is in the chat if you'd like to reach out to him with any questions. I've also placed the link to our post-webinar survey in the chat on SurveyMonkey. Your CE credit is not conditional on completing that survey, but we do appreciate feedback that you can give us on this. Oh, and we have a question. How can we register for the 324 webinar? Excellent. Once we get approval from the Division 18 CE committee, we'll be able to send out the link for everyone. We're in the process currently of applying for CEs for our final 2 presentations in this series. So stay posted, and those links will be coming out via email, hopefully in the next week or 2. You're getting a lot of appreciation in the comments, Ron. People are saying it was a fantastic presentation and they really appreciated it. So thank you for sharing your wisdom with us today, and thank you all for your attendance. This was a wonderful presentation. The recording will be posted later for those who were able and unable to attend. I'll send out the slides and the recordings as well. So thank you, everyone. I guess we will wrap up for today.
All right, yeah, thanks everybody for your interest. Hope to see you again